Good evening, everyone. Thanks for joining us for tonight's program. We'll begin in just a couple of minutes. Hang tight, and we'll be right back. We'll be getting the program started momentarily. Be right back. Hello, and thanks so much to everyone for joining us tonight for Ask Me, our educational webinar series. My name's Audra Hines, Vice President of Care Services for the ALS Association Golden West Chapter. I want to give a big thanks to our generous sponsors, the Morris Family Caregiver Initiative and the Ron Malone Care Services Fund. Programs like this one tonight are not possible without this significant support, and we thank these families so very much. As we move into a new year, our staff of 16 care managers remain connected and committed in supporting each of our families who are facing the challenges of ALS. If you need emotional support, we're here to help with more than 30 Golden West chapter support groups each month, many that are topic specific. If you need additional medical equipment or assistive communication devices, we can help through extensive equipment loan programs that the chapter manages. If you need information on specific topics related to ALS, we can help with a wealth of online and hard copy resources available to you. If you need a referral to an ALS specialist or clinic, we can provide information on more than 26 certified or affiliated clinics in the Golden West chapter area. If you need financial assistance in paying for something that's related to living with the disease, your care manager can help you navigate your benefits as well as assistance programs that the chapter may be able to provide. Please go to www.alsagoldenwest.org to check out our services as well as our lineup of all upcoming groups and events. As always, these are free of charge and everyone in our communities are always welcome. I'd now like to introduce Annie Brashem, Deann Del Rio, and Patti Giallanzo, who are the fabulous palliative care team from John Muir Health System in Walnut Creek, California. They're going to tell us more about palliative care tonight, what it means, how you might be able to utilize this important type of care, and answer any related questions you might have. Annie, Patti, Deann.
Hi there. We're all really glad to be here with you today. I'm Deann. I'm a nurse with our palliative care program.
I'm Annie. I'm a social worker.
Hi, everyone. I'm Patti. I'm a nurse practitioner with our program as well, and very excited to be here.
Thank you guys so much. I'm going to let you take it away now with your presentation, and then we'll follow up with some questions afterwards.
Sounds great. I'm going to go ahead and kick it off by sharing my screen here. We have a couple of slides to share with you as we go through this. Give me just one moment. There we go. So like Audra was saying, Annie, Patti, and I were part of the palliative care team here in the Northern California area. And we're really here to talk with you more generally about what palliative care is and what it can look like, the sorts of things it has to offer. And with such a big group, I think we're actually just going to jump in and talk a little bit about what exactly palliative care is. And so, you know, there's a definition that comes from a national group called CAPC. That's for the Center to Advance Palliative Care. And it's actually a really perfect overview. So I'm actually going to read it. Palliative care is specialized medical care for people living with serious illnesses. It's focused on providing patients with relief from the symptoms and stress of that serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and for their family. Palliative care, it's provided by a team of doctors, nurses, and other specialists who work with the patient's other doctors to provide an extra layer of support. Palliative care, it's appropriate at any age, at any stage in an illness, and can be provided together with curative treatments. And so this definition sounds lovely, right? Reducing symptoms, reducing stress, quality of life. But I think the question sometimes is just, what does that look like? How does palliative care help relieve symptoms and stress? How do we help people have the best quality of life? And so, we'll talk soon about kind of the variety of symptoms that we often help people who are living with ALS kind of cope with, the spasms, the sleep difficulties, the things that can really affect the quality of our days. I think that palliative care realizes, though, that it's a lot more than just our bodies that are affected by a serious illness like ALS. We realize there's a whole emotional side to the experience. Sometimes fear, sometimes uncertainty, or just kind of trying to make sense of this thing happening in our lives that we maybe weren't expecting, and trying to figure out how it fits in to the story of our lives. And there's a practical side too. Just, I'm needing more help with day-to-day things. How do I get by? How do we do that? And palliative care provides support for these things too. So the team has a lot more than doctors or nurses, like the definition says. We often, palliative care teams in general often have social workers, chaplains, and sometimes even other team members who can help with kind of this big picture. And so we help with the emotional support, with practical resources. And that can be anything from helping people be aware of support groups like this one, or talking about literally, where do I call to find some help in the home? What does that look like? And all of this support that we're talking about, it's not just for the person who's living with ALS, but also for all the people who love them and are caring for them and about them. And we provide that emotional support and that practical support to that whole team of people too. I think sometimes, we see people have questions about all the medical information they're getting from the different specialists who are involved in their care, or they just have questions about what to expect in the future. And palliative care is there to help answer those questions, really devote time to just explaining things in a way that makes sense. And I think one thing that's special about us too, when we're providing information and answering questions, we really try to do it in a way that respects what you do, or maybe even what you don't feel comfortable talking about in that moment. There are times when we want a lot of information. There are times when we want just a little bit, and there are times when we don't really want to talk about that at that moment in time. And palliative care really honors where people are, where they're coming from. Sometimes people are wanting a chance to talk through things with their family, talk things through about what's important to them. And palliative care will support those conversations. It's an opportunity for the people who care about the person with ALS to just all be on the same page about the big picture of what's happening. Sometimes families will actually feel like, we'd rather talk about that more privately. That's something we would handle on our own, but maybe we need some guidance. And so sometimes that's what we do, is we just coach people and we let them know, here are some ways to start the conversation. Here are some ways to kind of share together. So again, just trying to be flexible to what people need. But what we really specialize in, I think, is getting to know people, understanding what's important to them, what's important to their families. We talk about how the palliative care team can really, help people plan for the future, support them in making medical decisions that feel right for them. And the key to doing that is understanding what's important so that those things can line up. Those medical decisions and the treatments that are offered can really support whatever is most important in your life. I guess another thing that's really important to know about palliative care is there's a lot more time. I can't speak to every program, but the usual palliative care visit isn't the typical 15 or 30-minute visit we might have when we see our primary care doctor. These are longer visits where we really have a lot of time to understand where you're coming from and who you are, because that's really essential to us being of help. So that is a very long list of kind of all of the things that we can do. But I think what a palliative care team does actually really depends on you as an individual. What we do for any two people, it never looks the same. And you really are in control. You decide of all of these types of things, what's helpful, what's not. And you let us know when it's helpful too. And so that's kind of the big picture of palliative care. I do want to take a look. There's a little graphic down at the bottom of this slide here. It has kind of a light blue area at the top there and a dark blue area at the bottom. And it's kind of showing the experience that we can have when we have a serious illness. And that dark blue area, actually the light blue area, these are meant to represent the treatments that we use to control our disease, the things that we do with our doctors to try and live longer, maybe even cure our disease. So this is the Rilutech, this is the feeding tubes, this is the clinical trials. And you can see, where there are different amounts of this over time. And then there's the dark blue, and that's meant to represent palliative care. These are all the things that can be done to manage our symptoms, manage our stress, and just try and maximize quality of life in any other way that we can. And kind of what this graph is showing is that palliative care is that dark blue area is given right alongside all of the disease treatments that we're getting. And there might be times where people need a fair amount of palliative care, and there may be times where they don't need as much and the palliative care team is more in the background. It really depends on the individual. And you can see that dark blue, the palliative care, it's not replacing all the other things that we're doing for our disease. It doesn't replace the neurologist or any of our other doctors or team members. It's an added layer of support. So that basically the idea is while you're getting all of that care for your ALS, you can still be receiving support from palliative care to feel the best you possibly can while you're getting those treatments. I think one of the questions that had come up for this group is kind of, when is the right time for palliative care? And I think this graphic addresses that a bit. It's really whenever you're feeling like you would benefit from any of these things. Right from the beginning of your diagnosis, there can be times where you feel like you might need a little bit of this, maybe not much, and you may not need much for a while into your diagnosis, but anytime you feel the need for these sorts of things we're talking about, palliative care is perfectly appropriate. And we can talk a little bit at the end about, what it means to qualify for getting into a palliative care program, because I think that varies a lot from program to program. And so maybe in the Q&A, we can talk a little bit about that. I know that one of the things we mentioned, though, that palliative care does is that it offers an opportunity to talk a bit about the future. And I think our nurse practitioner, Patti, is going to talk a little bit about that.
Unmute. Hi. Thanks so much. Great introduction. So yeah, one of the things, that's really important at any stage is to really think about advanced care planning. And this really involves learning about different types of decisions that might be made, and considering those decisions ahead of time. And it's really letting others know, both your family and your healthcare providers, really about your preferences. And these preferences are often put into different forms that we have here. You can see there's the advanced directive, which is a legal document that goes into effect if you're unable to speak for yourself, or if you decide, at any time that you want somebody else to be making decisions for you. And this could be, this could happen at any time. Another one of these that we use is the 5 wishes. And that's also another type of, it's another unique way for you to kind of talk about different wishes that you want at the end of, at any type of, or along your care. We also use the PULSed form, and this is called a physician's order for life-sustaining treatment. And it really gives patients more control over their end-of-life care. And this includes medical treatment, any kind of extraordinary measures, and this can include ventilators or feeding tubes, and includes CPR. And this is signed by both the patient or their decision maker, and then alongside a physician or a nurse practitioner like myself, a physician's assistant. And this can be filled out with an RN or a social worker too. And this really helps prevent any kind of unwanted or ineffective treatments, and helps reduce the patient's suffering and family suffering. And it really ensures that your wishes are honored. And so these forms can be filled out at any time, and they can be changed and updated. And so as things progress, you can always make adjustments. But I think the biggest thing is to really start having the conversations about the types of care that would be appropriate to you, or to have your goals and your wishes known. So.
Can I add something, Patti?
Yeah, go ahead.
Oh, so these forms are valid in California. I know the PULSed form is what we have here in California, and then the Advanced Healthcare Directive through Prepare for Your Care and 5 Wishes are valid in California. I know that they're valid in other states as well, but for those of you who are out of state, just wanting to make sure we're using a form valid in that state. And other states, it might not be called a PULSed form, it might be a different color, but most states have one, and they're similar in nature, kind of talking about these very specific medical interventions.
Thank you, Annie. Next slide, Deann.
Yeah, 1 second. It's just frozen. Give me a moment.
No worries.
Let's see. That's why it's frozen. Oh, okay. All right. Go ahead and talk about symptoms.
Go ahead. Yeah.
Here we go.
Here we go. So I know a lot of the, it's one of the things that we do in palliative care is really want to address any symptoms that are coming up. And these, we take a lot of time to really get to know you and take a holistic approach and really understanding what's important to you and what makes sense and how to treat all of these different symptoms. And this is just a very short list of them. So there's definitely other ones, but I know a lot of our focus, can be around things, early on, you might be experiencing different pain issues, and we really take time to understand, what makes sense to you and offer different interventions for you. These can be from non-pharmacological, and then we can also do different pain medications, and it's very varied. I know a lot of symptoms that do come up and that are, from early on can be this shortness of breath, and sort of understanding different stages and how to treat that and prevent, there's a lot of anxiety and other sort of symptoms that come along with that. And we talk about, medications and when, going on to different non-invasive ventilators and things like that, and sort of really sort of preparing for different symptoms that might come up. We do know there's a lot of anxiety, and this can lead to also some depression. And so really taking our time and getting to know you and understanding what symptoms are most bothersome, and then how we address these. It takes a whole team approach. And so we'll definitely always include, we'll have respiratory therapists, speech therapists, occupational therapists, and physical therapists to help guide. And as things change, we lean on and use our entire team to really support you and in your needs as well. I think a big part is also the psychosocial support that we have with the stress and anxiety with the families as well, and just being able to support everyone involved. So I know there's a lot, and to go into each one could be an entire presentation in itself. So I'm going to keep it on the shorter side. So, all right, next slide.
I'm working on it. It's just slow.
Perfect.
I think I'm going to start chatting about it, though. I think it's a pretty general slide, but we realized that another thing that comes up a lot in ALS is, medical decisions. There can be some pretty significant ones in ALS that come up just kind of along the course, whether that's feeding tubes, tracheostomy and ventilation, or even clinical trial participation. And when it comes to these decisions, there aren't really any right answers. It's really a very individual kind of thing, very personal decision. And so, what does the palliative care team offer as we're dealing with these kinds of things? We try to help people piece together information like we were talking about before. So when a specific, decision is coming up, kind of just trying to understand what's happening, what all the options are, understanding what those options really look like for you and your family. We really try to drill down to, what does it mean to have a feeding tube day to day, hour to hour at home? What is that like for the person with ALS? What is that like for their family? We talk about whether the decisions are reversible. If I don't like this decision, can I change my mind later on? And we also kind of look at what timing feels right for you. And so we kind of weigh out the benefits and the burdens of each of these things very much in relationship to the things that you identify are really important in your life. And we're a bit of a sounding board as you just kind of think through these big decisions. And so these are huge things to talk about. There's no right answer. So the palliative care team is providing this space, right? We also are really careful. We don't push people to think about or talk about these things before they're ready. And yet at the same time, we do let people know that these are things that we're thinking ahead can be helpful. Oftentimes we kind of expect that there will be warning signs that'll let us know this decision is approaching, that maybe the time is coming where we need to decide about a feeding tube or decide about a tracheostomy. And sometimes the unexpected happens and the decision is in front of us when we aren't expecting it and we haven't gotten warning signs. And so when those situations come up, sometimes people aren't well enough to let us know what it is that they would want. And so hearing from you ahead of time can help, us as your medical team try and make sure that we give you the best care possible, the care that you would choose for yourself if you were able to speak up. And talking about it ahead of time can also be a gift to the people who love the person with ALS. It can be a tremendous relief for loved ones to know that if they're in a spot where they unexpectedly have to make a decision for the person with ALS, there's relief in knowing that they're choosing something in line with what that person has expressed they would want. And just like with the documents that Patti was talking about earlier, people are allowed to change their minds. We expect it over time as our illness changes, our life changes, we may change our minds how we feel about any of these decisions. And so it's an ongoing discussion, and palliative care checks in with people. You've told us maybe this is how you feel about a feeding tube, or this is how you feel about a tracheostomy. How are you feeling now? So there's a lot of room to kind of think it through and change your mind as you go. Patti or Annie, is there anything you would add to that? I know it's a big topic. All right. I think Annie's going to talk a little bit about palliative care and hospice here.
Yeah, so I'm going to take a guess, and I think this is one of the biggest questions that we get from folks. What is the difference between palliative care and hospice? Are they the same thing? People are often really nervous about palliative care and associating us with hospice, and I think all of that is very normal, and I think that we actually have some really good news with regards to that. So as you can see from the graphic, I like to think about it that palliative care is this umbrella term for caring for people with serious illness. And then hospice is like the beach ball under the umbrella, or like one arm of the umbrella that is for kind of a certain group of people with serious illness that kind of have a few different, meet a few different criteria. So as Deann was explaining earlier, palliative care is very broad, very general, can be provided for any serious illness at any stage, at any age, alongside any treatments that are happening. It's just this added layer of support underneath. And then hospice care is a special Medicare or insurance benefit of services provided where somebody lives. And it's primarily for people who have a limited life expectancy. And I think that oftentimes we talk about the 6-month life expectancy. That's kind of what a lot of our doctors or medical providers are thinking about. And I would say that that is the technical definition, but I think we like to think about it as, limited life expectancy months, year-ish, if everything went as we think. But we know that illness and treatments and life doesn't go as we think, and so that's not really a cutoff. If somebody is living longer than 6 months, they can renew with hospice. If people improve, they can graduate from hospice. So it's not like it's not a fixed time period. And so that's the one criteria for hospice. The second is wanting this comfort-focused approach. So it's a comfort-focused medical care provided where somebody lives. So it's for someone who's saying, every time I return to the hospital, I'm getting, it's more of a burden. I'm getting more tired. It's hard to rebound from the hospitalization. Getting to my appointments or dealing with all of my doctors and it's all getting too much. And I really just want to centralize my medical care and focus on my comfort. And with hospice, with ALS, I think that it can be a little bit gray in what people provide. I would say we don't want to, I wouldn't assume, or we can always have a conversation about if feeding tubes, trach, ventilation, those are all conversations that we have with the hospice team. It's not, when you sign up with hospice, it doesn't necessarily mean that those are going away. It really depends on each person and each family and each situation, and it's a conversation that you would have. So that's kind of hospice in a nutshell. Well, there's a lot more information about hospice that I could go into, but kind of the difference. Another big difference between palliative care and hospice, which I alluded to, is hospice is this insurance, kind of your insurance will pay for it. It's a Medicare benefit. And even those folks who don't have Medicare can qualify. Palliative care is not as nationally organized or reimbursed in the same way as hospice is. Hospice has the same set of services, the same thing throughout the country, and palliative care is more up and coming, and so each program is a little bit different. What they provide, when they provide it, it's not as streamlined or like concrete. So that can be a little bit tough, and it's hard for us to talk to what other programs do, but we can try our best. Hospice, you will get they have nurses that visit at least once a week, often more, depending on need. They have home health aides that can help with bathing and other things around the house. Doctors, nurses, they provide all medications, all equipment. And they have this 24-hour hotline that you can call any time of day or night, 2 a.m. on Christmas Eve. You're having a symptom. Instead of having to go to the hospital, you now can call the hospice agency, and they'll tell you what to do over the phone, or they can come out and see you at home. So it really allows you to remain comfortable at home. And again, I use the term home broadly, and it can be a facility, a house, an apartment, anywhere that somebody lives. So the hospice does not provide the 24-hour care that people generally end up needing, but they provide a rich benefit of services to help folks during this time. And they also offer bereavement support after somebody dies for their loved ones, logistical and emotional support afterwards. Am I missing anything? Deann and Patti, there's so much to say about it.
No, I think you did a beautiful job, and I think the questions that we get, I can see that they started popping up as we started talking about hospice. This will be a good guide for where we take it next, if that sounds okay. Were there questions you wanted to throw out there right now, Audra, based on what you're seeing?
Yeah, absolutely, I can. If you guys, do you have more slides you want to go through, or totally up to you? If you want to take questions now, that's totally fine too.
So I think we have just one other slide with some resources, and we can touch base about that whenever fits well. So if there were specific questions around hospice, we're happy to address those first and then come back to resources. And
sure. One thing that came in was a question sort of surrounding maybe some of the specifics, Annie, that you just mentioned in terms of having perhaps a doctor come into the home or home health aide. Is that specific to hospice service, or could that fall under palliative care service as well?
So it's a great question. I can say with hospice, it's this specific benefit. So that, yes, nurses would be coming based on needs. Some of our patients get visited daily by a hospice nurse. Some people it's once a week, and the home health aide. Doctors kind of come in as needed, but the nurse is always in contact with the doctor for any changes. Hospices have social workers, chaplains. Prior to the pandemic, I don't know honestly how it's working now, but they would have volunteers who could come. Some of them have massage or music or pet therapy. So it's really a wide range of services depending on each agency. It's honestly a little bit difficult to answer the question about palliative care because each palliative care program is different. So for example, our program, you have 3 of us here, this is about half of our outpatient team. So unfortunately, we don't provide the things like home health aid and bathing and things like that. We're fairly conversational. We would do home visits and things, and ramping that up with the pandemic, and a lot of telephone support. We can be very responsive by phone when people call. We're getting back to people within, less than hours. So that's how we kind of function. I think that so we're a palliative care program within a health system. There's also palliative care programs that work, that are aligned with home health agencies or hospice agencies. And because they're aligned with those agencies, they may be able to garner the home health aid support a little bit easier, or they may have different regulations or offerings of services. So I would say that it kind of depends on each specific program and also on each specific situation. Some insurances are actually paying for palliative care. I know Contra Costa Health Plan and Blue Shield of California have some contracts with agencies in our area. So I feel like I can't answer the question because it's different. So if there's specific ones, we can try to go there.
Sure, that makes perfect sense. Thank you. Yeah, we're actually getting some great questions that are super relevant here. One is, do you interact directly, sort of personally, with the clinic medical staff through John Muir, or is your role rather to coach the family and the patient to do so? That's
a great question. I feel like we do both. It really depends. Sometimes people really would prefer to interact with their doctors directly and gather information themselves and hear it directly. And so we'll coach people and let's make a list of questions together that is really going to get you the information you need. But our team is also very proactive about reaching out. We do communicate directly with the specialists that are involved, not only at John Muir, but also outside the system. So for example, we have ALS patients who are seen at ALS clinics at UCSF or Sutter, and we'll reach out to those clinics and talk with their specialists, their neurologists, to go ahead and gather the information that's needed, and to help people connect. And we work really hard to communicate what we're gathering from you about what's important, to try and make sure the whole health team understands, because if we're going to work so hard to figure out what's important to you and kind of what your goals are for your life in general, so that your medical treatments can support it, we want to make sure the medical team knows what they're shooting for with you. So absolutely. And again, I think like Annie said, I can't speak to how exactly other programs work, but I think by and large, palliative care does work really hard to communicate with other clinicians, to be a team alongside the rest of your team.
Okay, great. And what about, could someone access palliative care if their physician hasn't initiated it yet? How do they do that? If they've maybe heard about it, maybe they've heard about it tonight, how would they go about starting that?
That's a great question too. And so certainly talking with your physician is a great way to start. They may or may not be aware of the resources in the area, because like Annie said, palliative care is still new. And I guess I would actually warn folks too. Some of the information we're sharing with you today is things that even our nurse and doctor colleagues and other specialties aren't aware of. They oftentimes also believe that hospice and palliative care are the same thing. And so some folks will get kind of an interesting reaction when they go to one of their physicians and say, hey, I'm looking for some palliative care. Can you help me out? Mm-hmm. And kind of get this reaction like, oh no, it's not time yet, not realizing that palliative care is any age, any stage. So I guess I would just let you know about that. And absolutely, you can reach out to your primary care doctor. I think if you're involved with an ALS clinic, I would really be hopeful that they would be aware of some community resources there. But then beyond that, you can look within your area yourself and reach out to palliative care programs in your area. When you give them a call, just let them know that you're exploring and find out what their referral process is. You know, for our program, we do need a physician at some point to refer you, but we're often able to work with you to help you get that referral. And individual programs will be able to kind of walk you through it. And I don't know if any of these Get Palliative Care resources that we have here on the slide would help people find individual programs. I'm trying to remember myself, and I'm not sure.
I don't. I will look that up while we do the.
Perfect. Okay. Great. This is actually a question I had myself, and I see it asked on here a couple of times. Can you give us an example of maybe what a palliative care appointment might look like? Would it be sort of the person coming in and meeting with each of you, or would you sit with them together? Or just maybe if you could go through sort of a typical visit, if you don't mind, that might help people understand too.
Yeah. So this one is tough because I feel like what we cover can be so different, but I think in terms of the substance of it, you know, our team pre-pandemic would sometimes go into the home, or other time people would come into our clinic. Right now, we are certainly doing plenty of visits on the phone or by video, and for our team at least, and I think with the other teams that I've spoken with, typically the visits, any of the involved team members for that day when you're visiting with them are typically all involved together, because we work as a team. We want to address all your concerns that are coming up immediately. So you might have both a social worker and a nurse, or a physician, or a chaplain, and you know, it could be any combination. Sometimes it's just one or two of us in our team. On rare occasions, there might be more. I guess I would also say too that you might find that over time, as the palliative care team follows up with you, It may be that maybe the social worker is going to be checking in with you every 2 weeks to provide some support, because things have been really stressful and there's been a lot going on. But then you'll still have visits with the physician at other times, or with the physician and the social worker together. So it can be any different combination of folks. And I don't know if that gives you a sense, but when people come in, palliative care works really hard to address whatever's coming up with you. And so we always have ideas of things that might be useful to check in about. We want to hear how things are going. We always have thoughts about things that might be a concern. We usually really start with whatever's top of mind for you. So that's really our agenda, is whatever's most important to you, and that can really take the focus of the visit.
Sure. Okay, and related to that, if perhaps a patient isn't sure if palliative care is right for them, or if they're ready for hospice, they're just not sure, would a palliative care agency go over all of this with them and sort of talk that through? Okay.
Absolutely. That's oftentimes a big part of the conversation. When is this right for me? When did I want to consider hospice? We walk people through that all the time.
Okay.
With both palliative care and hospice, there's no real commitment. So, for example, with our program, if somebody said, this has been great, I think I'm good, we would say, great, call us when you need us. And I think most palliative care programs would be similar. So there's no issue in starting and stopping. And even with hospice, if somebody signs up with hospice and 2 weeks later, whatever, a little while later, they're realizing, actually, this isn't the care that I was looking for. I want to go back to the hospital, or an emergency happened that hospice isn't responding how I thought, and I want to go back to the hospital, or just in general, this isn't what I thought. You can come off hospice and you can get reconnected with your previous doctors, with the palliative care program. It doesn't have to be final.
Okay. Not so black and white. Okay. Great. How about if a patient's denied palliative care for a, quote, lack of skilled need? What skilled needs could be used to justify this in ALS?
So Patti or Annie, please feel free to jump in. I think when I hear the term skilled need, it makes me think of the insurance requirements that exist out there for getting access to services, like a nurse coming to the home to help with, with a feeding tube, or to help with a wound, physical therapists, occupational therapists, and all of these things fall under the umbrella of home health. And they do have this requirement. Insurance requires that there be a, quote, skilled need. The idea that a licensed professional is really required to deliver the care that's needed. And so it makes me wonder, sometimes some palliative care programs can be associated with a home health team. And so that might be where there's some pushback with those specific programs. And when it comes to advocating for skilled needs, that's tough. Typically it's wound care, it's medication management. It's when we have a specific medical condition that requires education or stabilization. But those skilled needs, the challenge with them is they're typically short-term. Insurance isn't always very generous. We know that the nurse coming to help change a wound dressing is really helpful. And they teach us how to do it. But it would be really nice if they kept coming and kept checking up on us. It feels like there should be a skilled need, but insurance might view it differently and say, well, the family has been trained now, and you don't necessarily need a skilled person coming in. I'm not so sure about how that ties in with, having a skilled need for palliative care per se, because typically we think of that differently. I sense that it's probably because it's tied into a home health situation. Annie or Patti, do you have anything you could think of to add to that?
Yeah, I was just going to say, for our program specifically, in our palliative care program, there aren't a skilled need requirement, and that the big difference is that's usually for home health. And so I can't speak to other programs like Deann saying that might be tied to a home health, but palliative care, from my general understanding, is that there are no skilled need requirements for it, and it's available to anyone, any age, any stage. So it's not looking at an actual skilled need.
Okay.
Yeah.
Got it. And related to that, actually from the same person, they're asking, does the palliative care intake help me and my family create a care plan?
Yeah. So I think this could vary from program to program, but when you're voicing to a palliative care team in general that you want to look at making a plan for your care, I think they're really going to want to engage with you in that. And they're going to want to find out from you what kind of plan is going to be most helpful. And absolutely, it may not be that they'll come in and proactively say, we need to have these forms filled out and check boxes, but they're going to want to meet that need if you're saying, I need a plan. Absolutely.
And another person asks, how can we get a relative to try palliative care, someone who's apprehensive of trying it? Maybe there's a fear or a stigma around it.
Yeah, I think there's a lot of fear and stigma. And I can think of a couple of things, and I'll have Annie and Patti jump in. Sometimes the myths that Annie was talking about, that palliative care and hospice are the same thing, or this is just for the end of life, or it's only when you want less treatment. If we help to give people information that combats those myths, it can feel a lot safer. The idea that this is just an extra layer of support for whatever it is you want and need. It's not going to take anything away. It's not going to really change anything other than supporting you. I think that can be a really, really big relief. And in terms of, how do you kind of get those misconceptions, kind of clarified? You have this presentation. There's some really great material on getpalliativecare.org that lays out what is palliative care and what it isn't. And sometimes just giving a family member those resources to look at and realize this is what it is can sometimes alleviate a lot of worry. Annie, did you want, just saw you disappear. Did you want to add anything based on the resources? Maybe cover some of those?
Yeah, sorry. Were you going, Patti?
Go ahead.
Okay. Yeah, so Get Palliative Care is a great resource, has a lot of general information, a lot of information specific to ALS, and we have two websites here. One is a little bit more about symptoms. The top one, the second one is kind of palliative care in relation to ALS. And I did notice on the second link that if you scrolled down to the bottom, it was like, you could search for palliative care programs in your area. And I actually searched for my own zip code. And I can say that it's not 100% perfect on what it's going to say, but it'll give you an idea of different places that you might be able to start, whether for my area was John Muir, Sutter, UCSF, Kaiser, Palliative Care of the East Bay. And there were lots that I know about that weren't even on there, but it kind of gives you just somewhere to start. And I would just say that for those folks who are wanting palliative care and their loved one is maybe really worried, we hear you. It's a very common thing, and meeting with the palliative care team for the first time, again, you're not signing up for anything, nothing necessarily has to change about your care. It's just an added layer of support. And yeah.
I was just going to say one other thing to that too, is to for the family members that are, recognizing that there's this need, is that it's for everyone involved. So it will, it supports you, and to kind of get curious with your loved one that is feeling more resistant, or there might be some fear around it, but coming at it from a place where you're needing that extra support, or the family member is. So, and that can be really helpful, kind of alleviate that too.
Absolutely. Absolutely. Thank you. Couple of questions specific to hospice. Wondering if you could clarify if feeding tubes and ventilation devices are allowed during hospice. I know this comes up for a lot of our families, sometimes being denied some of these services if they're using certain types of equipment. Could you comment on that just a bit?
Yeah, I can speak to that. I know that there's definitely challenges with certain types of ventilators being covered. And I know that this can be a big issue with different agencies. But I do know that if you kind of go to different agencies, you can see which one works for you. And feeding tubes generally are a little bit easier and they can be covered. But I find if you have a certain type of ventilator, that's can be a challenge. And sometimes you have to switch to a different one. But it doesn't mean that you can't have, hospice care at that time, or even if you're on feeding tubes, you can't have it. You still can, you just might have to switch to something else, or it does get a little bit tricky. And different agencies have different requirements. So sometimes you might need to look at different agencies. And Annie or Deann can speak to that too.
Yeah, no, I think that's right on. And, sometimes palliative care teams can kind of help you navigate that a little bit. They'll sometimes have an awareness of what various hospice agencies in the area will and won't accept. And they'll also kind of walk you through the process. Sometimes, like Patti was saying, it takes meeting with some hospice agencies and talking out, what your goals are and what your equipment is, to see what they'll accept. And palliative care teams can kind of help you navigate that process, and kind of walk through that.
Great. That's very helpful. Thank you. Another question actually from one of our chapter care managers. Some people living with ALS are hesitant to go on hospice because they feel the agency doesn't know as much about ALS as their ALS Clinic team does. How often, if at all, do hospice agencies collaborate or work with the patient's ALS Clinic team or allow for this to happen? Give a sense of that. I know you guys are within one health system, but if you happen to know.
I feel like that's a pretty challenging one. I don't know if, Patti, you feel like you have an immediate answer. I think that that is a really common concern for a lot of folks with ALS, right? Their ALS Clinic knows more than anyone about the realities of their day-to-day needs. And that's a legitimate concern. I think in terms of general advice that, we've often shared with our patients, oftentimes people they have close relationships with their ALS clinic, and to talk with that ALS clinic about, hey, I'm thinking about this potential transition, but I'm really worried about losing access to this knowledgeable resource that can really address my needs. Hearing from them what their experience has been with patients who transition with hospice, what their availability is, even if it's just to take a quick call and answer a quick question. They may not be able to see you in the same way that they were able to before, but they might be able to be this backup system in that kind of limited sort of way. And sometimes that's enough reassurance. I think it's tough to answer because we don't work in hospice agencies to know exactly what that looks like. And I'm curious, Patti and Annie, if you have other experiences.
I don't specifically with the ALS clinics, but I think definitely, like you said, Deann, having that conversation is really important. But I also do know that different hospice agencies have ALS special nurses that are very versed in being able to work with ALS patients and families. And so I think that's also coming, going and doing research on different agencies and really finding somebody that is specialized in that, because it is such a delicate, nuance, and you've had all of this care if you do come from a clinic, so you're very used to that. And so I think communicating and finding an agency that does have the specialty would be very beneficial. And then I do know that sometimes physicians, once you do transition to hospice, sometimes your physician that you might have a really close relationship with can actually stay on. And so that's something that is an option as well. So.
Yeah, so it's always an option to ask your ALS clinic. They have recommendations of hospices that their patients have appreciated in the past, or that they could stay on as the attending physician potentially. And I also just want to say that palliative care and hospice are both great. And if it doesn't seem right for you, if it doesn't make sense because of whatever is happening or whatever equipment that you use, and I think that that's fine. It's not a requirement to participate in any of these programs. I hope that in the future we can expand the scenarios in which we can provide palliative care and hospice to accommodate more folks. Sometimes it can feel really limited, and so hopefully over time that will change. But we advocate for you to have the care in the way that you want within the unfortunate restraints of the healthcare system. So.
Gotcha. Do you find that most insurance plans cover palliative care, even HMOs? That's a question that came in.
So I think that palliative care doctors and nurse practitioners will bill your insurance. So as long as who they are, as long as I feel like, yes, you could get a consult with a nurse practitioner or doctor that's contracted with your insurance company, and they would bill, and it would be like any other specialist visit. To access a nurse or a social worker or a home health aide or all of these other services that some palliative care programs provide, I think that's dependent upon each program.
Okay. And we have a comment from a care manager too, not a question, but just to follow up on that, just if as people are kind of shopping around, and if they say, if it's a hospice agency and they say they know a lot about ALS, ask for references to find out for sure. So that's just a good tip for people who are looking for that. Quick question that follows up on a couple things you guys have addressed. Do you usually end up recommending hospice to your patients at some point if you know that there is a certain time period left in terms of 6 months, or is that a part of your process, or again just more of a case-by-case basis?
I think I can speak to how the three of us view that, and I can't speak to anybody else. But for our patients, we recommend hospice when somebody has that limited life expectancy and when their goals of care are related to receiving comfort-focused medical care in their home. So really focusing on maintaining quality of life versus quantity of life. And so when we recognize in our patients that that's the goal, we would bring up hospice. We don't bring up hospice solely because of a time frame, but it's the two pieces together. At least that's how our program works. I don't know if you guys have anything else.
No, I agree completely. I think it's a lot less about what we recommend and a lot more about trying to understand what it is you want, and then letting you know the resources we think are going to best meet your goal. And so if what you're telling us is important to you and what you want looks like hospice, then we'll bring hospice up. But we're not here to recommend our own thoughts. It's really based on your needs, your wishes.
Okay. And a good question here. She says, recognizing that palliative care is general and broad for any serious illness, how does someone find or connect with a palliative care team with specific ALS experience? Knowing ALS is pretty rare, she's wondering how many health professionals are skilled or trained in this. She's in the North Bay area.
I can say that it's the same thing with hospice. It's trying to find recommendations. Also, or ask for recommendations. Also, if you are trying to connect with a palliative care program and they assign you a nurse or a doctor or whoever, and that person you're learning maybe doesn't have the experience, you can ask, hey, do any of your colleagues work with ALS patients? And our program, we do have a handful of ALS patients or other folks with similar type illnesses. And so I would not say we are an expert in ALS as much as an ALS clinic, but we do communicate with them, get all the information. We do our research. I don't know that there's a perfect answer. It's the same thing with hospice. It's just trying to get recommendations and making, advocating for yourself that maybe this person isn't just, is there someone on your team who has this experience, and it's okay to change nurse or doctor or whoever.
Absolutely.
And we also know that, unfortunately for ALS, because it is rare, you guys are your best advocates. You know yourselves best, and unfortunately, sometimes we do learn from you, but we appreciate it when we do.
Wonderful. Thank you for saying that. Does palliative care evaluate for and prescribe medications such as antidepressants or sleep aids?
Absolutely. So we work with medications often. We can't speak to how every team functions. I have heard of some teams across the country that will make recommendations and have a primary care doctor, have your ALS clinic actually do the prescribing. As for our team, we will actually do the prescribing as long as your team is okay with that. And I would say that, all of these things that Patti was discussing about how it's very individualized to what you need. I would also add that palliative care tends to really kind of follow closely. We don't want to willy-nilly add medications and not check up and see if they're actually helping. So oftentimes you'll find that there's close follow-up to see how it's going, to see if it's working, to adjust if it's not, and also not to leave you on a medication that doesn't seem like it's helping. But absolutely, medications for all of the symptoms that were listed, including anxiety and depression.
Great, thank you. Thank you for helping clear that up. A good question, if I have a family member that doesn't support my decisions related to my diagnosis, it's interesting, can I invite them to my visit while I work through preparing an advance directive or the post form?
Yes, we actually encourage it, and that's something that palliative care clinicians all specialize in. Annie, Patti, myself, we all train in communication, and that process of kind of coming together with family, other people who love us and care for us, and talking together about what's important can be really tough conversations, and we absolutely support that. We encourage you to invite whoever you might appreciate having in those visits. We welcome them.
Okay. Great. This is kind of a cute question. It says, it sounds like palliative care is a blend of direct care and case management and referrals for care. They say, am I getting it? Do I get what it is? Is that right?
I'd say, yeah. It's many palliative care programs are small, and so they're not able to really envelop everything that somebody needs. And so it's a lot of helping people connect with what else exists, and we recognize that sometimes what else that exists is not enough. But yes, I think that is a great, I might steal that actually. Explaining what we do.
Yeah, I like that too. We have come to the end of our questions for this. Wait a minute, no. I think we have come to the questions. You guys did a fantastic job answering these. I really want to thank all of you for being here tonight. This was an awesome presentation. Thanks so much. We're really grateful to each of you for your time and your commitment to the Golden West chapter, and honestly to the ALS community. And I want to thank everybody on the call tonight for your participation and your important questions. Very helpful, and I think we all learned a lot. Deann, do you mind just stopping sharing your screen?
Absolutely.
That's great. Thank you guys so much. I just want to mention, Jennifer, are you able to put up the next slide? Mention a couple of quick things as we close. Just want everyone to please save the date and join us virtually in the coming weeks and months for a variety of webinars and events that we're hosting. On March 24th, please join us for an information night about the Golden West chapter and all we have to offer. If you know families who are less familiar with our services too, please encourage them to register. And we have a virtual ALS Hoop Fest on April 17th that will be lots of fun. As well as the next installment in our Ask Me series on estate planning coming up in April. And we round out the month with the Jim Tracy 5K virtual event. So please visit our chapter website. Stay tuned for future communications about those exciting events and programs. And I do just want to close with saying our programs are made possible by individuals and families and foundations and companies who care deeply about the ALS community. Your generous support fuels absolutely everything we do, and everything we do advances the search for effective treatments and cures for ALS. And if you too would like to support the Golden West chapter, please consider making a donation at give.alsagoldenwest.org. Please watch for the short survey on tonight's presentation that you'll receive via email in order for us to plan for future programs like this one. Thanks so much again, and we'll see everyone next time. Have a good night.